surgeon with Davenport Surgical Group, and I had the opportunity to do my surgical residency for 5 years in Rochester from 1986 to 1991. Thereafter, I came here to practice, and I've had an ongoing relationship with my friends and colleagues still in Rochester, and had the opportunity to be the president of the Mayo Surgical Alumni Association at one point. So I keep close tabs on those folks and use them frequently as a reference and source of additional information for my patients.
I'm Kathy Weideman. I trained at the Mayo Clinic in internal medicine and endocrinology. I was there for 4 years and left there and was able to open an endocrine practice in the Quad Cities in Davenport, and enjoyed 30 years of practice here.
I'm Mindy Hass, and I'm a general surgeon also, and I'm with Unity Point Clinic, and I'm actually a Quad Cityan, born and raised here, and I also did my surgery residency at Mayo. I was there from 1996 to 2001, and I came back and joined Unity Point, and I've been here about 18 years. I also keep in touch with friends at Mayo and recognized a lot of faces, as I'm sure Joe did on the screen. Surgeons that have been there a long time that we still keep in contact with.
Hello, I'm Kostas Konstantino. I'm a medical oncologist. I'm practicing here in the community. I did my training at the Mayo Clinic in hematology oncology from 94 to 98. And as everybody else has said, we're keeping in touch and in every opportunity we have. Thank you.
Hello, I'm Rick Ripperger. I'm a retired orthopedic surgeon. I trained at the Mayo Clinic from 1976 through 81, and in orthopedic surgery, and also I did a upper extremity surgery fellowship there from 1980 through 81. Came to practice in Davenport immediately afterwards, practiced here for 34 years before I retired recently.
Thanks. We know we saw in the clip that there are several medical advancements and theories that have come through Mayo Clinic, including the radical idea that germs caused infections that people were skeptical about. So in your careers, can you just tell us a little bit about some of the medical advancements that you've seen that you found really exciting? And I'm just going to pass the mic and you can share it as you will.
It is interesting when Mike Carton asked me to be on the panel. It made me think and remember about several things about the Mayo Clinic, but one of the questions I knew that was going to come up was what were medical advances? And in the field of orthopedics, and I'm sure it's the same in other fields as well, they're too numerous to mention. But if I think back to when I was a beginning resident in 1976, the first total joint arthroplasty, the first total hip arthroplasty in the country was done at the Mayo Clinic 5 years earlier in 1971. The first total knee was done in probably 73 or 1974. Arthroscopy was not being performed in the orthopedic department at that time. Fracture care fixation principles were just being codified right around that time. And just for example, in arthroscopy, that started at the Mayo Clinic when one of the rheumatologists went to Japan and visited Dr. Watanabe, one of the developers of the original arthroscope. And when an orthopedic surgery resident wanted to see and perform arthroscopies, he had to do a rheumatology rotation with this physician. And so that was probably in 1976 or 77. And if you could just think of how the arthroscope has changed things over the years, I mean, all of you know that, well, somebody's going to have his knee scope, somebody's going to have his shoulder scope, but now it's hip scopes, it's elbow scopes, it's small joint scopes, and it's scopes that are outside of the joints into soft tissue as far as the field of orthopedics. And in general surgery, it's just another part of their routine practice nowadays. In the total joint arthroplasties, that started out in the hips. Dr. Mark Coventry in the orthopedic department performed the first one at the Mayo Clinic, and about that same time he started what has become one of the largest total joint arthroplasty registries in the country. And it's just one of a multitude of registries of diseases and treatments that the Mayo Clinic carries out as just a part of their regular training and practice program. There was not an MRI at the Mayo Clinic when I first came. The first CT scanner had been there only 3 years, and that was the first CT scanner in North America was at the Mayo Clinic. It was interesting that the MRI scanner that was first put in there was around 1977 or 78, and it was put in the room where the human centrifuge was. And that was a room where people were put through a centrifuge and a G machine to help develop the G suit. And as part of that process towards the end of World War II, they were monitoring those people with a pulse oximeter, which has now become standard use in every operating room in the country and in sleep labs. But at any rate, the first MRI went into that room. So those are some of my memories about developments in orthopedics over the years.
Thanks.
I'll speak a little bit about oncology. I think that one of the biggest advances we have seen over the last several years is that we understand much more about the biology of the tumors. So we're kind of moving a little away from staging and sizes and where something is, and focus more on what type of cells are making the tumor and how they respond to different treatments. We are slowly moving away from chemotherapy, which is a treatment that doesn't really recognize which one is the good guy and which one is the bad guy. Basically, chemotherapy attacks cancer cells as they are dividing, but chemotherapy does not realize which one is a tumor cell and which one is a normal cell. So as we understand more about the biology of the disease, there are treatments that are more targeted against cells that express certain chemicals that are recognized. So whether we're using a biologic therapy or immunotherapy, I believe that those treatments are significantly smarter than chemotherapy. Unfortunately, we're not there yet where we can get rid of chemotherapy, but I think over the years, maybe in the next 10 or 15 or 20 years, we may be talking about a totally different class of biologic agents, and maybe not what we have done over the years. It is still, though, something that we frequently use. So the immune system is something that we getting deeper and deeper into, and we're trying to harness the power of the immune system. And I'm sure you all see the ads and the commercials on TV and so forth, and those are the realities of the practice today. One of the things, in talking with the other people in the panel, I think and that's something that you have seen on your screens here about how the team operates. We are also seeing more and more value in multidisciplinary approach to cancer, and we work closely with our surgical colleagues, closely with our radiation colleagues, and so we realize that helping patients with cancer is not a one-man's job, and frequently we work together in a multidisciplinary way. And I believe that this concept is going to evolve even more in the future. So, thanks.
In general surgery, and I'll just kind of touch on a few things because Joe will want to talk too, but there's been so many changes since I finished residency. It's hard to believe. It's almost like we're doing a different practice today than when I got out of residency. But one of the big things that they pioneered at Mayo when I was in residency was some of the changes in how we treat breast cancer, and specifically what we do with lymph nodes. And Mayo really pioneered the sentinel lymph node biopsy, which is what we still do today. Basically an idea of doing less, where you're taking less lymph nodes out, and that was something that they were starting there, and we still do here. And I think I might have been the first one that was doing it in Illinois. They might have been doing some in Iowa, but many of the changes in breast cancer are some of the things and treatments that are different, genetics and such, and some of the high-risk models are things that have changed today that are really very new. And of course, surgery today is so much more minimally invasive, and so much, when I left residency, we were doing only gallbladders and hernia repairs laparoscopically, and today we do almost everything laparoscopically and even robotically, so just huge changes.
When I graduated from medical school in 1976, people with diabetes checked their blood sugar by checking their urine. And that lasted until about 1980. While I was at the Mayo Clinic, there had been developed a way, if any of you had diabetes that long, know that we finally were able to have patients be able to check blood sugars at home. And I think that's one of the major changes that has occurred with the management of diabetes. It wasn't developed at the Mayo Clinic, but we adopted the care very, very quickly, and it rapidly developed itself. Endocrinology is a disease of the endocrine hormones and the glands that produce them. And several changes have happened, not only in diabetes, and I'll go back to diabetes again, but some of the things that have happened that are just amazing to me is that there are organs in the body that now are considered endocrine hormones that we didn't even think were endocrine hormones. For instance, we know that fat now makes hormones. We know that maybe the skin can make hormones. The muscles make hormones. Hormones are coming from the gastrointestinal tract makes hormones. And they're using that to be able to treat these diseases now in new ways. Most of the endocrine diseases that people have most commonly are diabetes and thyroid disease and osteoporosis. Treatment of osteoporosis has progressed quite a bit, and we now have ways to even measure bone density and to treat them. And I think one of the biggest ways we will impact care for people in the future is to be able to prevent osteoporosis and fractures. Hormones are probably also involved in aging, and I'm not sure I am going to recommend that we all live a whole lot longer, although there are some people I hope do. But I think we can help people live more healthy longer, and it may involve the use of hormones correctly. In terms of diabetes care, I think the most significant thing that has happened, partly as a result of being able to check blood sugars at home, is that we are developing ways to integrate blood sugar monitoring and insulin delivery, so that people no longer have to check blood sugars as frequently and can have their own insulin delivery system that self-adjusts to what their blood sugars are. And it has been shown to significantly improve blood sugar care and keep the blood sugars closer to normal, which we now know does make a difference in the complications. So lots of changes, and I think one of the things that I learned at the Mayo Clinic is to always be looking for these new developments and what is going forward with care, so that I'm not afraid to begin to adapt them into my own practice and to know how important it is to give our patients here in the Quad Cities care that is new and updated frequently.
Yeah, everybody, yeah. I've had 4 arthroscopies, Rick, thanks, including a bone and cartilage transplant in my knee. I think Dr. Hess covered it pretty well in general surgery with this revolution of minimal access surgery. And I had the kind of good fortune of being in my training program when the concept of using a laparoscope to look inside, which the gynecologists have been doing for decades, suddenly seemed like a good idea. And it was because there was a little tiny digital camera that was developed that could attach to the scope so everybody in the room could see what you're doing, not just one person looking through a laparoscope. And with it, as she pointed out, we do virtually everything now with minimal access. We probably do 80% of our colon resections, 90% of our splenectomies, almost all of our gallbladders, appendicitis. We did 5 appendectomies yesterday at Genesis. They were all done with a laparoscope. All 5 people went home today. Those types of developments compared to when we made an incision this big and went through 3 layers of muscle and you're in the hospital 5 days with a risk of infection about 30%. These are tremendous. Our ability to resuscitate people who are critically ill, critically injured has been revolutionized over the last 30 years I've been in medicine. We do things now we would never have thought to do. We don't try to close abdomens when people are critically ill. We know if we leave them open and use special devices, we salvage people. We don't kill their kidneys. We don't kill their lungs, and we can keep them going. Our ability to keep people well nourished while they're critically ill and can't eat has been revolutionized with intravenous nutrition. Our ability to send information, the computerized record has a lot of problems with it. But one of the great things I used today, I had a patient with a very unique issue, and I didn't really have the specialist here to help me deal with it. And so I called my colleagues at the university and I said, I think she might benefit from a procedure you might be able to do that I can't do here. And they said, send us the x-rays. So we called the radiology people and said, send them the x-rays. And in 10 minutes they had the x-rays, and their interventional radiologists were looking at it and said, we can help you with that. Those types of things that we can do now, whereas before you just had to describe it, take it on faith. Now when we know we send a patient there, she's making a trip that's worthwhile. She didn't really want to go because her family was here, but we thought it was her best way to be treated. And when we told her that, and we said, they've already looked at this, they know they can do it for you. She was very accepting of that idea. So the technology that we've had outlined in orthopedics, the ability to look at tumor cells and understand their biology, the ability to test blood sugars, all that is being incorporated into our practices of medicine on a continuous basis. And it's really been exciting to be in medicine during this time. It probably is actually all the time. My dad said the same thing when he was a doctor years ago. So I think that you kind of heard a kind of a synopsis of it, but a lot of it's going towards that. I think it might be reasonable to make comments about things that haven't changed too. And I think that people who go into medicine, people who go into nursing, people who work in the hospital, they do it because they love it. They love caring for people. They love working with people. They love helping people be healed from illness when they can and comfort them when they can't. And those things haven't changed. I read an article about it today about the humanity of medicine, and that hasn't changed a bit. I think you'll still get great young doctors and nurses who will give you great care.
Thank you. To continue a little bit along those lines, you talked about the things that you've seen, and a couple of you talked about what you think will happen in the future. Let's go there a little bit more and talk about where you see the future of medicine, if you were going to make predictions. And if I can make it a couple of part question there to also say, how do we make sure those advancements do happen, and what's the key to that?
Oh, good. I get to go again. I think that you're going to continue to see us be less invasive. We won't have to do many really big operations, and we'll continue to enhance our ability to do things with a needle guided by a radiologist who's very skillful, or a vascular surgeon who can drive a catheter, or a cardiologist who can treat a heart rhythm abnormality with electricity and cryoablation, et cetera. We've seen this already. I think you'll see more prevention of disease. It's already happened. When I came here 27 years ago, I did a colon cancer operation every week or two. And then Dr. Pratt's sitting up there. He and his colleagues proved that if you get a colonoscopy, it'll take out polyps before they turn into cancer. And now, fortunately, I only have to do a colon cancer case like every month or so. And that's tremendous that our community, as it continues to grow, we can